We're going to talk about the top 10 pearls and pitfalls in nutrition care for your IBD patients. Just a couple conflicts of interest, not related to this talk, but just so you have them. All right, number one, fiber is likely your friend, not your enemy. So we know that there's a swinging pendulum of fiber use. Should we be restricting? Should we be including it? So dietary fiber can alter the gut microbiome, improves GI symptoms, reduce inflammation through fermentation. You get production of short-chain fatty acids like butyrate, but it's probably more complex than the way we used to think about it, of just soluble versus insoluble. The general take-home message today is, instead of restriction, use texture modification, and I'm going to show you what that looks like. On the right, you just have an example of what these types of fibers may be, including some of the novel fiber sources. And I say maybe your friend or likely your friend because there's this very interesting article from Heather Armstrong showing that maybe specific fiber sources like inulin or unfermented beta-fructans are actually worse in patients who have active IBD. So this is an area of active research, but in general, think about, instead of restriction, texture modification. We want to prioritize whole foods and not fast foods. So what does this mean? Focus on a Mediterranean-style diet, lots of whole foods, plentiful fruits and veggies, whole grains, lean proteins like fish, nuts, seeds, healthy olive oils. You want to tell your patients to limit their red meat use to once a week. Reduce saturated fats, emulsifiers, carrageenans, all these thickeners and sweeteners that are in the diet with maltodextrin. And this is from the IOIBD guidelines, just again stating the exact same process. Don't over-supplement. We see these patients who come in, they're on 20 supplements. They have an entire baggie there to show you, and they prioritize taking their supplements over eating real foods. We want patients to eat whole foods and not be worried about supplements. Many of these supplements can cause nausea, they can cause other side effects, rashes, diarrhea, joint pain. They're hard to time. Some have to be taken with meals, without meals, and so then patients are really struggling. They're also super expensive, so save your patients the cost. We often recommend a chewable multivitamin for our patients who have any absorption issue. That starts the absorption process in the mouth and gets it going for our patients. Flintstone is a great brand. There are a couple of others that are out there. So one vitamin, check micronutrient levels, and supplement by what they need. Don't over-supplement. Texture modification. So we just talked about what this means. The smoother, the better. If that's a good take-home message, I'd love for you to take that home. So instead of having whole raw nuts, having creamy nut butters. Instead of fresh corn, corn flour, corn breads, corn tortillas. Turn those chickpeas into hummus. Veggies can be turned in, they should be cooked and really nice and soft. They can be pureed into a soup, like the creamy broccoli soup. You want to try to avoid whole grain breads if our patients are having lots of symptoms, instead doing sourdoughs. Reduce the textures of steak into ground meat so that it's easier to tolerate. Remember, applesauce is still a fruit for patients. If it can be made with no sugar, it's really a great option. It's very easy to tolerate for our patients.
No skins.
So Steph, why smoother is better?
Which one?
Why?
Is smooth better. So it's smoother is better because so in our patients with strictures, we know that it's going to pass more easily. Okay. And also by removing some of the insoluble fiber but keeping the soluble, you get the benefits of the fiber without actually causing much roughage in the colon, so it reduces their diarrhea. It's not going to change the inflammatory process, but it's going to make them feel better clinically, reduce their bloating, reduce diarrhea, reduce pain.
Should we be peeling all the fruits with skin on them?
So we do recommend when patients are having active symptoms to peel and cook their veggies and peel their fruits, exactly. In patients in remission who are doing really well, they don't need to. They can go back to a regular diet. So this is all about for patients who are having active symptoms. Not all oral rehydration solutions are the same. So we really want to make sure if our patients are having diarrhea, they're exercising a lot, they're sweating, we want to provide the right recommendations. Many of these products on the market are marketed for electrolyte loss towards children, towards athletes. We want to make sure they have the proper glucose to sodium ratio. So the best things to use are the Drip Drop, Liquid IV, and Gator Light. Those are the best, and they have the proper glucose to sodium ratios for our patients. And these are the ones to recommend. Liquid IV comes in a 1 stick per 16 ounce, Drip Drop 1 per 8. The Gator Light is almost perfect. If you can recommend your patients add a pinch of salt, it's even better, but we'll take it off the shelf if they're going to drink it that way.
Is Gator Light available in like CVS?
It is. It's available everywhere. It's made to compete with Pedialyte now, so it's the new market. The G2 that you used to see, the lower sugar Gatorade, has been pulled off the market, and this is the new product. Use shakes for healthy weight gain. So we use a ton of these shakes for our patients. They come anywhere from 220 to 530 calories per day. Oftentimes our patients who have lost weight, they're looking to gain 5, 10 extra pounds. You want about 250 to 500 calories per day in extra weight. This can be hard. Patients don't want to meal prep extra food, cook more options, have more to eat. If you just have one extra shake, one of the higher calorie shakes per day, that can be a nice, easy, convenient way to add some calories without adding a lot of work to their diet. These shakes come as dairy, as non-dairy forms, so there's whey protein and pea protein. Most of them are kosher, most are lactose-free. There's no need for peptide formulas. Oops, sorry. So those formulas that you used to hear about that need an NG tube that don't taste very good, you don't need any of that. And they all really should be taken orally at this point. Caution with restrictive diets. So we've heard a lot about different diets, lots about the specific carbohydrate diet as well as CDED, and we use these diets as therapeutic diets. We want to make sure we're identifying the right patient for the right diet. So you want to make sure your patients don't have an underlying eating disorder. That's incredibly important. You want to be sure that the diet is only used for a short period of time. It should be either a bridge to a new therapy, induction of remission with a goal to get them to a Mediterranean-style diet. And you want to treat the diet as you would any other biologic. So if you wouldn't start somebody on a biologic and not check and see if they actually had endoscopic or histologic healing, we should do the same with a diet. If you start somebody on a diet as treatment, we use an eat to target as opposed to treat to target strategy, and we want to make sure you're identifying if it's working. Hold off on probiotics. I know this may cause a little anxiety in some, but the data on probiotic use is really quite variable, and there isn't great evidence supporting their use. There were a couple initial studies in the UC patients with BSL-3, and it's had its moment, but nonetheless, a lot of these studies have not been duplicated. There's question about what's in these products, and we don't currently recommend any probiotic use. Instead, I'd love patients to get probiotics from food, such as yogurt and kefir, and most importantly, it's about including those soluble fibers from fruits and vegetables and other plant foods that actually supports a healthy and diverse microbiome. It's not about giving one strain from this pill or one strain from that, but about really supporting the entire microbiome for our patients. Micronutrient assessments based on patient history. So I have a general panel that we use for everybody, but then we really try to cater this based on what their clinical history is, what medications they're on, what their diet is like. If they're avoiding fruits and vegetables, make sure you're getting a vitamin C level to rule out scurvy. If they're having a lot of diarrhea or an ileostomy, you want to look for their electrolytes, their zinc. Draining fistulas, all of these things are very important. They're on methotrexate, make sure their folate is okay. So really try to cater this so that you're not just ordering a broad panel of expensive and potentially unnecessary vitamin levels, but you're doing it specific to what your patient needs based on their history, their medication use, and dietary patterns.
Is folate really a problem with ileal resections? Hi, Dr. Gold, I'm Marshall Cohen.
Hi. So we've
And B1?
we've seen some there are questions about B vitamin deficiencies, and so we just want to make sure we're covering all of our patients for sure.
Folate too?
Have seen folate, yes.
On the opposite end, sometimes we see people with vitamin B12 greater than acid.
Yes.
What do you do about those patients?
So it's a really good question. We see these vitamin B12 that are over
Vitamin
2,000.
B12.
Yeah. Vitamin B12 over 2,000. So the first thing I do is I ask them if they're supplementing. Many of them maybe didn't tell us that about their supplements, or they're taking it in some way. They're getting a nutritional yeast, which is a ton of B12. So I ask them what they're taking in, and if they're supplementing, I have them stop it. B12 is stored. It's the only B vitamin that is actually stored water soluble, so I would not try to run those levels super high. If they're not taking anything in, we start to look at the diet to see where they're getting it. There's got to be a source from somewhere. If there isn't, you can also repeat it in case there was a lab error. Lastly, screen all your IBD patients for malnutrition. So malnutrition affects about 30% of the patients we see in clinic, 70 to 80% of those who are hospitalized. Malnutrition is independently associated with a ton of poor outcomes in our IBD patients, increased post-op complications, disease flares, poor response to biologics, decreased quality of life. All of the guidelines have now come out in support of the fact that all patients with IBD should be screened for malnutrition, both at the time of diagnosis and then regularly thereafter. This can be done by your medical assistants. This can be done very easily with a couple of questions. Our system here, we use the MUST tool, and we've actually built this into Epic so that it's it's automated, very little work on the provider standpoint. We've created a best practice alert, so the provider opens the chart and they get the alert if the patient is high risk for malnutrition. It also allows you to have that conversation while the patient is sitting there. So you get that alert when you open the chart, you can realize they're high risk and have that conversation, ask them what they're eating. Again, high-value components of the MUST, unintentional weight loss in the last 6 months, look at their BMI, but not BMI alone, and are they having a lot of symptoms? Are they eating? Sometimes patients say, I'm eating a regular diet, but you should ask them what that means, because that may be tea and toast for them. That may be their regular diet, so it's important to just ask. Those are the top 10 pearls and pitfalls in IBD and nutrition, and thank you so much.
That was amazing. I think people are gonna have questions. I have one question that I think Dr. George might find an interesting question also, and that is, what do you think of CURQD?
It's a very good question, and if they're at our nutrition seminar, we're actually going to have a lecture from the group on CURQD. There's some excellent data looking at it, but you just need to be careful about the side effects in terms of pulmonary disease, and so that's one
So
complication.
the risk is in patients who have a history of pulmonary disease?
It's actually not. There was a small, in this study looking at CURQD, we think it's from the QD, not the curcumin. There was a patient who had pulmonary hypertension complication, and so we're a bit hesitant. Some patients are actually getting, some providers are getting echoes before they start patients.
There's one other.
Are you not getting an echo?
No.
Oh, okay.
So to this point, Ryan with Jim and Shomron, I mean, we have applied for a grant to start a clinical trial of combo with Velo.
Combo with what?
Velo plus
Uh-huh.
curcumin.
It's curcumin or CURQD?
CURQD.
Curcumin is Israeli.
There is one other interesting complication that's arisen, which is a few patients have had intussusceptions
Wow.
of the ileum into the colon. Yeah,
Symptomatic or just?
symptomatic,
Because of?
but on CURQD, and we don't know why.
What do you do,
Two-
like a
two-
scope
two
to
reports.
decompress them?
Well,
No, well, there were CT findings and they stopped it and they decompressed on their own.
Why did they get the CT? They were clinically obstructed?
Yeah, abdominal pain, severe abdominal pain, cramps abdominal pain.
What's the incidence? Do you have any idea?
I think it's
thousands of
case report.
patients,
It's case
but
report
case
only.
reports,
Yeah, it's
yeah.
all of this. The pulmonary hypertension.
Case where there was a hepatitis person, the guy was from Thailand, who was.
and we don't really know the mechanism either, right?
The mechanism of how they believe it works is on the ARH receptor in the colon.
Yeah, but but I'm thinking about
The pulmonary hypertension, no, it's the queen dye, not the,
And the pulmonary hypertension case, just to be very upfront, the dose was incredibly
Megadose.
mega dose. Yeah, so very high.
Right.
Steph, thank you so much. That was absolutely fantastic.